Okay, so here we have a 37-year-old gentleman. He was intoxicated. He's currently unemployed, smoker, and that is his trauma bay kind of humerus x-ray. It is distally neurovascularly intact to the best of your ability given his level of intoxication. It is a closed fracture. So maybe just sort of initial thoughts on this particular fracture based on the limited information I've given you.
Is it isolated?
Yes, well, so that's my limited information. So this patient was on a motorcycle, and so he's a polytrauma patient. So multiple other fractures, many of which are open, and so those are initially treated immediately. And now you're sort of assessing him at post-injury day 3. Patient's subsequently been put into a kind of a sugar tongue splint, and this is where he's at. So multiple lower extremities.
Is the forearm the same side, ipsilateral?
Contralateral.
Contralateral side.
I mean, it's a polytrauma patient with multiple injuries, especially lower extremity. They need to get up and mobilize. So you need to fix their upper extremities and get them mobilizing. So I would fix this with a plate and let them weight bear accelerate immediately, use crutches or a walker. That's what I would do.
I think if you look at the patient, unemployed, smoking, alcoholics, probably somebody I'd like to avoid operating on. So in isolation, I probably would treat this non-operatively for those reasons. But if it's in the context of the other 3 limbs being injured, it would make sense to fix this stably enough that he could start to move it and use it right away, I think. So I probably would agree fixing it.
And the goal being movement, so you would let him weight bear.
The goal being that you fix this so the plate's strong enough to let him weight bear it right away. And I think Phil Walensky had this paper many years ago saying it's safe to walk on a plated humerus as long as you do a good technical job of plating it.
Excellent.
Yeah.
Nail?
Yeah, biomechanically it was shown. No, I wouldn't use nail, I use plate. I mean, biomechanically I was done with the large fragment plate system with the staggered holes. And most of us now tend to use small fragment, so it's not so applicable. But if you have good bony apposition, and actually this patient is one of those patients, even who's isolated, it's one of these fix and forget because you don't want to see him a lot. You don't want to follow his non-union in clinic. You know the kind of patient.
Yeah, I do.
Like, yeah. Kind of patient.
So
maybe you're getting
I'd even tend to
non-unions.
fix him if he was isolated. So
I wouldn't advertise using a 3-5 plate. Most of us still use large fragment plate for a humeral shaft, unless it's like a 90-pound small individual, especially in a polytrauma and someone that you want them to get up and you know they're going to be non-compliant, you want the strongest construct. So for an adult humeral shaft, 4-5 large fragment plate and screws.
If you're going to let them weight bear, can you give a little details about that construct? So like 3 holes on either side and 6 cortices on either side, or a longer plate?
Depends, yeah, it depends on your fracture. Like if you can lag it and plate it, I would do 3 screws up and down.
Let's say this one, you're going to let them weight bear.
This one's a bit comminuted, so maybe 4 screws up and down, but you just want balanced fixation.
Okay.
So
yeah,
if I'm bridging this, I might go a bit longer.
like I said, the original study was done with offset large fragment plates. Then people went to single line large fragment plates, and now people are using small fragment plates.
I don't know who these people are. Maybe they're in Quebec. They're not here.
I'm getting there. I'm going to quote it right now. So the COT study showed that it was surgeon choice what plate went on, and some of the plates that went on were small fragment plates.
You would agree, Ed, though, that for a male polytrauma patient,
Absolutely.
a 4 or 5 plate is standard of care?
Absolutely. I try to do that all the time.
How about 2 plates, 3-5 plus?
Yeah, you can do that, or you can just put 1 plate and be done. But yeah, if you're going to do 3-5, some people dual plate, and I don't understand the reasoning, because it's not like the clavicle where you can say, oh, I'll do mini plate so it's less soft tissue irritating, so we decrease the risk of hardware removal. The humerus has lots of soft tissues around it. They're not going to feel the implant.
I think the argument would be if you're going to let them weight bear right away.
Which we know is safe with a single 4 or 5 plate.
Yeah.
I don't know the answer, so I don't have a comparative groups to tell you.
But we already know it's safe with a large fragment plate, so what are we trying to prove? Like, how can we make it better? It's already proven to be safe.
I'm going to flip to what was done here. So, humerus fractures, mid-diaphyseal, especially transverse. Now, this one does have some comminution, as was noted, for sure. Lots of torsion. That's the mode of failure for most humeral diaphyseal fractures. So, it's one of the rationales for dual plate constructs is to provide some additional stability for rotational stability. So, thoughts on that?
In the COT study, were a lot of the dual-plated?
No, preceded this sort of advancement. So in fact, I can comment that none of the patients were treated with dual plating.
In the COT study?
Correct, that is
And how many mechanical failures were in the COT study? Of the 45 or 50 patients, how many had mechanical failure of the
There were
plate?
2 non-unions in the operative group.
So 2 out of 50?
It is, no, it's higher than that, 84.
So two out of 84 failed with a single plate, and they weren't really mechanical catastrophic failures, they're just delayed non-union, basically.
I'm thinking, is
Yeah.
what I'm just thinking
I mean,
about.
commonly it's the pull-out of the screws.
If I had a technique that
non-union,
worked that worked 82 times at 84, I'd use it every time,
But I have a
frankly.
case that, anyway, yep. I was going to get there, but that's fine. You can see some lag fixation was used here, provisional fixation with an anterior plate, and then dual plating technique used here. Patients obviously allowed to weight bear. That's the important thing. That shouldn't change if you're, no matter what you're doing. The entire indication for this particular fixation was to let this man get up and mobilize with his additional injuries. On Saturday, I'm going to show some biomechanical data looking at dual plating as well, so we can continue that conversation. Good. That was the.
Did you ever see him again, or that was it? He was gone.
He's still currently in my practice, so
Okay, fair
yes.
I would add that it takes much less time to put 1 plate and 6 screws than it takes to put 2 plates and a whole bunch of other screws. I mean, if we're looking at length of OR, meaning more costs and more risk of infection and more complications.
This sounds
So
like
that
a
is
great
also
thing to
another-
study prospectively, and so we do have some of this
Great.
underway, of course, looking at.
I think my argument is that almost all the failures I see with single plates.
Maybe because
I'm just putting
maybe
out
it's
there.
at 3.5 single.
Yeah, but
No, it's
almost,
not that- it's
almost
not that-
all the surgeries you saw were single plates, so that's totally biased, right?
The
Obviously-
plates are not breaking though, right? So commonly it's not the plate is bending or breaking, it's the pull-out of the screws.
Yeah,
With torsional
I don't know. I don't
forces.
have, knock on wood, I don't have that. Like, I love that 4-5 plate. Put it on, get out. Especially if it's comminuted, you just put screws on. And a lot of people argue for doing the MIPO technique for these, right? Not even opening it up. That's what people are doing elsewhere. Make a small incision on top, small incision, slide the plate down, as long as you don't hit the radial nerve. 3 screws up and
Little
down,
detail.
and you're done.
Elsewhere that's
So-
being done, yeah. And then, so the other thing, and again, I don't want to take away a little bit of thunder because I want everyone to come back on Saturday morning so we can talk more about this, but there are some additional technical tips and tricks for how you can use a second plate for provisional fixation and achieving your reduction. So I'll leave it at that. 57, works as a roofer, slightly elevated BMI in this patient, likes to smoke intermittently while on the job. This case here is an isolated injury, and here are the initial films taken. So thoughts on this patient?
Are these films taken at the same time or separate times, Prism? Do you know?
Same time,
Same time?
actually, yeah. This is the AP,
I mean, the
two
film,
views, we'll
the
call
film on the right is alarming because he's got a transverse fracture, and we know that transverse fractures take the longest to heal, treated non-operatively, and there's significant degree of displacement there. So already I'm thinking this is one that's going to take, if it does heal, it's going to take a long time to heal with that pattern, that displacement. I might give it a week or so and see if it lines up better with a bit of time and gravity in the Sarmiento, but I'm already thinking this is one that might need to be fixed, frankly.
Yeah.
But isolated patients come to the ED. In our practice, at least, most commonly they are seen in clinic 1 to 2 weeks. Like we don't make that decision surgery usually in ED. They come in 1 to 2 weeks if there's an isolated injury.
And is that
Is-
being done in Emerge, just because I'd love to understand the landscape? So Emerge is splinting these, and then they'll refer to your clinic
Yeah.
in a couple of weeks.
Well, it's site-specific, right? So in our hospital, the resident would get called, they would see the patient, they would talk to the patient. If they want surgery, they'll stay and get done tomorrow. If they don't, they can go to clinic. If we're not sure, then they'll go to
I mean,
clinic.
depends on the practice, right? If you're busy, you don't have for these isolated upper extremity injuries, they may end up in clinic to see the orthopedic surgeon versus if you have time availability, you can sign up for surgery from ED.
Yeah.
I mean,
Patients with a BMI at 35 don't tolerate Sarmientos in general. Like, you can't get a good
I
reduction.
mean,
It's got a lot of
34 is
displacement.
not that high.
Yeah, it's, oh my God.
Relatively.
So it's maybe we're very skinny up north, but once you get to 35, like they don't They don't tolerate it. It's hard to get a Sarmiento on, even a mid-shaft. This is a slightly proximal to mid-shaft fracture. So I think those reasons would make me lean to more towards surgery.
I think this is one area in practice that's changed dramatically. I mean, when I was taught about this fracture, we quoted Sarmiento's work, which was good, but that had a 99% success rate, and we would almost never operate an isolated humeral shaft fracture. And I think the studies now that have come out that are randomized and prospective, one's the COT study, there's one from Finland, which is published, a couple other ones kicking around, show that the failure rate with non-operative treatments is 30 or 35%, which is much, much higher than we were taught. And failure doesn't mean non-union. It means patient can't tolerate the splint, there's an unacceptable displacement or whatever, but failure of the non-op treatment is much, much higher than we thought from the original work on this. So now if you want to fix this in the clinic or the patient wants surgery, I think you have good scientific backup to say, yeah, we can fix this and it's worthwhile because the failure of 35% is too high to accept for most people.
Okay, perfect.
Yeah, but it'll be a discussion with the patient. If he absolutely wanted surgery, you're on pretty good grounds now with those papers. Say, yeah, we'll fix it for you. If you said, no, I don't want surgery at all, they say, fine, we'll leave it in the splint and see what happens.
Yeah. Yeah, when we were in residence, we couldn't fix this. We weren't allowed to.
Fair. Okay, this is a really great discussion. Again, Saturday we're going to look at sort of some of the very now I think well-established indications, and this is definitely meeting those. Okay, so your colleague decides to go ahead and fix it. They've had a conversation, patients on board, and this is their construct. So comments on construct.
So this is a staggered offset large fragment plate. I mean, was there anyone here that would nail this?
No, I mean, I think plating's appropriate, but you have to do a technically good job. So they have, I mean, I'm not sure if they're going for anatomic fixation or bridge fixation. They certainly haven't anatomically reduced that displaced fragment, but yet they've put a lot of screws right around the zone of comminution. So if you look distally, there's only 2 distal screws in the shaft. The 3rd and 4th one are in the fracture. So if this fails, I would not blame the single plate. I would blame the reduction and just the general construct.
To be fair, they might have compressed that because it's that butterfly fragment. It just angulated through that as they compressed. But you're right, there should have been a longer plate.
I agree.
Yeah, perfect.
I wouldn't nail it.
Okay, good. So
Would not.
Would not nail. So the point here.
I mean, to be fair, I do plating too. I wouldn't nail, but if somebody wants to nail it appropriately, I don't think it will be wrong to nail this. It will be more durable. The patient will get back to work much sooner.
Well, I mean, this guy works as a roofer, right? So half the day he's carrying big things of shingles up on his shoulder, up on a ladder, and if for the main problem with nailing remains, insertion site morbidity, pain in the shoulder, no matter how you do it. We're in the 4th or 5th iteration of techniques up top. First was completely blind, then it was formally open, then it was trying to use the nail that went around the corner outside the GT. Now we're going to go straight down the middle and split them also. But that's the 4th iteration of approaches up top that I'm aware of to try and stop the problem with shoulder site pain. And I still see patients who've had humeral nails heal the fracture okay, but their shoulder hurts. And for a guy who's going up and down ladders all day with a pile of shingles on his arm, that would hurt. I think I'd avoid that if I could for him.
Okay. So he comes back at 6 weeks.
Uh-oh.
Yeah. Uh-oh is correct. So the point here being, as we've been discussing, the swing, I think, of the pendulum towards being very appropriate with our decision-making to offer surgical intervention, but needing to do that, of course, well. So Nilüfer said this very well, that the bottom, 3 and 4 on the distal fragment, they're in the fracture. The butterfly fragment was never reduced. We're now starting to see screws backing out at 6 weeks, and unfortunately, sort of said, go away, head in the sand, hope it works out, and of course it didn't. And so here we are now at 8 weeks. I think we've addressed why this failed and how this could have been managed a bit more appropriately. But what do we do with him now? We're 8 weeks.
Are we going to revisit the nail? So people from Germany in particular would have nailed this right away.
Europe loves nails.
There's a question because if you look at Bob McCormick's study, which was retrograde versus antegrade nails, the retrograde nails had a huge amount of shoulder pain as well. So the question is, what caused that pain? It wasn't obviously putting it in through the tuberosity, right? So, and obviously the Europeans have a lot better success rate for people getting people back to work with a nail, with a humeral nail in. I think a lot of it's technique dependent. This guy has a huge canal, so it could have been a nice one for a nail because frequently they're non-union devices because when you hammer the nail down, you want to get as much length as you can. You get into that narrow part of the humerus at the end and you just kind of distract the fracture by 1 millimeter and it's over. Like this operation was over in the OR, right? But it might have, could have, should have worked, but it should have, could have worked like this too. So probably, that was my Canadian conversation. So I think probably just needed a longer plate, like Nilüfer said, a bit with better technique.
At this point, you have to open this whole thing up to take that out, and I would debride it, pretend like it's infected, send cultures, and like the whole thing's open for you, so I'm not sure it makes sense to now nail it, because now you've already had the morbidity of opening it now. Retrospectively. Well, it's interesting you mentioned Europeans going back to work. If you actually look at recent studies looking at Europeans going back to work, they don't want to go back to work, and they don't work as hard as Americans. They take a long time to go back to work. Right. So
they have insurance.
They have a great social system in Europe where if you have a baby, somebody comes to do your laundry and you stay at home for 2 years, the husband gets 6 months off. So it's just completely different social support they have.
How many people here would nail a humerus on occasion, or it's in their repertoire to nail it? What do you nail it for? For this kind of fracture, or what do you do nails for? Pathological fracture? Pathological fracture.
I mean, pathologic fractures are very, I think, accepted or consensus on it that pathologic fractures will get the nail. Aside pathologic fractures, I guess.
I do it for lower demand geriatric patients where I just want to give them some stability to use their arm, and I may not necessarily want to make a big open incision. And if, they probably have cuff problems already, I wouldn't want to do a nail in a young person because I wouldn't want to risk that young person's cuff. At least not as a primary. Now, if it's, a 3-time failed something, then that's different.
There's a few options here, but you have to take the plate out, take broken screws out, debride the bone ends, and then figure out how you're going to refix it. When I've done these in the past, I always culture them, but one time in 3, on day 5, I get a call. It's grown some staph epi in 2 of the cultures. I was growing C. acne. So I treat all these like they're infected. And so when I get that culture back on day 5 or day 3 with one positive, I feel good about what I've done, which means a radical debridement. I clean it all out, 3 liters of wash, trim out anything that looks that are infected, shorten the bone ends a bit, freshen them up, then refix it, and that's dealer's choice. And I always leave a gram of powdered vancomycin now for the revision cases on the way out to mop up the stragglers. So,
would you ever plate laterally? I mean, this is lateral. Like I always go anterior at this level. Would any of you guys go lateral?
Anterolateral, I don't think it makes a huge difference biomechanically.
Agreed.
Yeah, I would just go back through the posterior incision because I want to see where the radial nerve is anyway.
Was done posterior incision?
No, this was on anterolateral, wasn't it? Anterolateral.
Was it done anterolateral?
Looks like, I mean,
plate is
proximally enough,
direct
looks
lateral,
like anterolateral to me, but you're going to probably go through you can reach there through posterior incision, but
Anterolateral.
Yeah.
Exactly.
I think then I'm going to stir the pot again. So non-union cases, single versus double plating.
There it is.
That's different. It's not a revision situation, so there's obviously you want to do something different than what you did the first time that failed, and I would say relatively acutely at 8 weeks, so you want to do something different for sure. You could talk about 2 plates, you could talk about a strut graft with a plate, allograft strut in the canal or on the medial side in the plate. There's lots of options here, but I think you need to do something different than what you did before.
Thank you for that. So, and he's obviously showing that he's using this arm. So yes, we have mechanical, reasons that we could have improved technically, but this patient is our torsional failure. He's a big arm and he's a working kind of guy. So he was revised, big long plate. Yeah. No, this is not mine. Revised, you can see the screws were not retrieved, so I think if there's any clinical suspicion at all for infection, as was mentioned, full workup, and potentially retrieving those and then spanning, obviously, where your residual holes lie. Thankfully, 12 months he was able to get back to work and he was healed, but a bit of a misadventure.
Any bone graft? Or
Again, I do apologize, not my case. I do not believe there was acute bone grafting, but I think that's something that, especially when you have low suspicion for infection, that's an excellent adjunct, for sure.
Would you bone graft, Mike?
So, sorry.
If it was clean and dry and it looked really atrophic at the fracture site, then yeah, I would consider bone graft or BMP, something
Like this
onto that.
is an early failure, right? So
8
later
weeks.
failures, I think, is easier to decide, like 6 months, 9 months, a year. You can decide is that biology problem or not. But like early on at 8 weeks, it's hard to know.
This is an acute failure at 8 weeks. He was a big guy using his arm in a marginally fixed fracture. I think that's why it failed. So probably just a good technical job of doing it either with 2 plates or a longer plate. It would be reasonable for him to get it to heal.
Agreed.
Looks good.
Plus
Good,
place
okay.
lateral, biomechanically inferior.
Typically, my non-trauma partners put the plate lateral, and then if it fails, I have to revise it, and I'm going to.
Okay, I do have one more if we've got time. because
I would
think it
just
might
say
tie
that I
this
would-
all together, actually, ironically, quite well.
But I don't think of ever like doing an isolated lateral
have time.
plate. I would put on a posterior plate. Like that, I didn't even think about it, but that's not ideally where you want it for biomechanics.
No, I agree. I think when you look at the humerus, it's very easy, and same with the radial shaft, to think you're anterior, but you're actually on the lateral side, especially the forearm, because it kind of rotates when you have both one forearm fracture. And a lot of people put the plate directly lateral, thinking that's actually the volar surface. I think it's the same with the humerus. It just rotates, and you're not really sure, or you're not in that environment routinely, so it's easy to get fooled.
Good case.
Yeah, let's try this one here. Okay, this will kind of weave everything together, I think, from the whole session in a lot of ways. So 79, this is a retired, lovely Italian lady, and she uses her arm like this a lot. But anyway, she has a BMI of 30.5. She's a non-smoker. She has well-controlled hypertension. Here are her initial injury films. That's what's available from your emergency referral.
Well, it looks like a sort of proximal fracture. There's a fair bit of comminution there. That's always a good thing, lots of bone exposed, potential healing. If you look at Sarmiento's work, the C-type fractures with lots of comminution healed quicker than the A or the B-type fractures. Overall alignment looks reasonable. I think I would try and treat this non-operatively in this patient, at least initially based on these films.
Anybody doing anything different?
No, unless she forces me to do an operation, I would send her home with a sling.
I think they do heal. I think if you really wanted to operate, you could, but then you're stuck with like a nail versus, you can do a percutaneous plate for these. So these are the ones that will heal with a percutaneous plate because they're going to heal anyway.
Yeah, that's a very...
If I was forced to fix this, it might be one that'd be reasonable for a nail like this. If you think of the incision you have to make to plate this formally be huge.
Exactly. Plus, she's European, so it's
Perfect. She'd love it.
And to your point earlier, yeah, she is 79 and she's pretty happy puttering around the house and providing.
With this alignment, it's hard to say surgery for me. My recommendation would be
But this is
start
like the
non-op.
clavicle we were talking about. You said at 1 week, what are they doing? Like, if they can move their arm and they can feed themselves and dress themselves, then you don't have to do anything. But if she comes and she's just unable to do her ADLs, I would nail it just so she can put her clothes on and feed herself if she can't do that.
Very reasonable point. Okay, so she's kind of splinted and emerged. Now she comes to your clinic, and this is the position. She's just at 2 weeks now. Stay the course.
Looks the same, pretty much.
I think that splint looks horrendous. I'd take it off and just give her a sling, and she'd be the happiest patient in the clinic when I took it off.
Excellent. So sling only, no Sarmiento.
It's too high.
Okay,
It's too high.
too high.
Yeah, and they get a lot of people get skin breakdown, and it's not a great.
I mean, at 2 weeks, you gotta switch to something, right? I don't continue after 2-3 weeks the splint, coaptation splint anyway. I usually give them a little expensive, maybe about shoulder brace with the pillow. I want to really treat this non-op, and I'm not trying to do surgery. I'm trying to avoid that varus. So that pillow, I think, helps to keep them more aligned.
Okay, I like that. So here's what is happening. She's placed in a Sarmiento, and you can see the position of that Sarmiento brace right at that, the middle part of the fracture. So in full credit, the Sarmiento brace was sort of put on. The alignment, for better or worse, was still very good, and so she is followed back now at 2 months. You can now see where the brace is, and I think this is actually very common. So you do a great job being diligent and putting a brace on, though we can argue that it was definitely too low, but the fracture was well maintained. This is now slid down. It's down by the elbow. This happens all the time. As mentioned, this is a proximal fracture that's really not immobilized.
It's basically levering right at the fracture
Correct.
site.
It
It's
is
worse than
just-
nothing.
Most critical
than
information at that point, I think there's gross motion or not.
Right, at 2 months, yeah.
Yeah, I mean, at 8 weeks, you will have an idea. If there's gross motion at that site, it's surgery, in my opinion. This my recommendation will be surgery. That gross motion at the fracture site or not makes a big deal for me, because sometimes the radiographic healing may be delayed. If the patient gets more comfortable, they start using, they have 90 degrees of abduction,
Yep.
and there's no gross motion with this arm, I may continue as it is. You're probably going to show that it's going to go to non-union, but most patients, that's what I would do.
Anything different? here,
That's
Lloyd?
just another way practice has changed. Like in the past, we wait forever for these. It's 6 months or still be motion. Say, oh, Mike, I healed my 9. Now I think there's pretty good evidence that if by 2 months or at the most by 3, if it still hurts and you're still mobile when you examine it, it's probably something you should just dig in and fix.
Is it
Fantastic.
still hurting or still moving?
So she's just a very pleasant, patient that sort of says, it's okay, and she's sort of, moving. And is it mobile on palpation? I believe at this point it would have been.
So I basically get them to raise their arm. If they can raise their arm and hold it there, then it's probably going to be okay. But that would be a test.
Perfect. And so in the COTS trial, the one, I think, main finding that's really important related to this case is those that were not fixed acutely, that went on to non-union, they never achieved baseline patient-reported outcome scores similar to the group that was fixed initially. So these patients do not do well with delayed sort of intervention many months out.
So that's another change before as well. So we say, leave everyone alone. This was for clavicle and for humerus. Leave them all alone. Most will heal, which was true. The ones that don't, just fix them down the road. It's the same operation, the same outcome. That's not correct. If you have a year of non-union in your shoulder, around your either humerus or clavicle, and we go to fix it, it's harder for us.
Yes.
Our complication rate's higher, and you don't get back to where you were as if you healed right off the bat, either with surgery or without it. It's just not the same. And so that's another thing that we know now that we can tell patients in the discussion that we didn't really know before, or we would tell them false information before. If you wait and get fixed later, there is a downside of that. It's not terrible, but you lose 10 or 15 points off the top, basically.
Absolutely. Okay, so this is where I meet her, is unfortunately at 4 months. And so we've still got this Sarmiento that is now like absolutely a non-union generator. It's causing this big long lever arm. She is now very unhappy, it's clear, and she's mobile at this point. So I didn't meet her at the 2-month mark, and she was mobile at 4. So that just illustrates the point of, let's just get on with it if you've decided this is going on to non-union. So we've got a 79-year-old now, 4 months out. I do have a CT scan. I'm wondering if you can push play on the video so that I don't skip forward to the next slide. Is that okay? There's a little video here. Can you push on the actual slide, just the play button? I don't know if that'll...
There we go.
Perfect. Okay, just because I thought this was helpful. Maybe one more time. So there we go. There we go. Thank you so much. Because she's 4 months, so we have abundant callus in places. So now how would you tackle this?
If you look at this fracture, just interesting, the natural history of this is the more metaphyseal and less displaced fracture heals promptly, which it has here, and then the more diaphyseal one, more displaced one takes forever to heal. And that's what's in the ones that don't heal, and that's what's happened here. But I think the proximal fragment is still, relatively speaking, lined up fairly well. Like sometimes you get that big spike will malunite, and then you have to figure out, well, do I break that and put it back into place and make the x-ray look better, or do I just leave it sticking like that and just fix it where it lies? So it's a tough decision to make intraoperatively sometimes, but I think the proximal piece fragment is probably healed to the head and shaft, and if you mobilize that, you can stick it in that defect and make it look pretty decent there. And
I think you have to do something with that spike. Like, if anyone wants to nail this and just leave this alone and put a nail in it, I don't think that's going to help her, because she's going to have that big spike and she's going to be very unhappy. So you're obligated at this point to open it up, whether you want to osteotomize that, put it back in the hole, or reposition it or whatnot. And then
Is it
if you wanna
deltoid on that
plate it
piece?
or nail it.
When you went in, was it deltoid on the piece? Yeah, it usually is, okay.
Yeah.
So you can't really throw it away?
No, yeah, no, it was definitely the
If that's what
entire
everyone's saying,
attachment,
just
yeah.
throw that away. Put a nail past it.
Well, you're not throwing it away, you're putting it back in the hole, in a different
point,
spot.
Nilüfer, the spike was very much an issue. So now she's moving through the non-union, and so when she moves her arm, that spike is actually becoming not skin at risk, but certainly a.
So these are actually pretty common, I find, in these elderly geriatric patients with these long spikes. I had a lady that had a nail initially, like sort of a similar thing. She had it nailed and came back and she was miserable. It hadn't healed, and that spike would just keep, moving up and down.
And to your point, it's because the deltoid insertion is there, and so it's going to remain displaced. It'll probably displace further over time. Yeah. What are you going to do with this, Ed?
Well, I think you're going to end up with an anterolateral approach and put all the pieces back together. But it's going to take a little bit of time and a little bit of exploration to make sure you don't do anything bad, but I think it's doable. It's not that hard. You can't nail it because the
it's too
canal's
late- too
full
late for him.
of like forming bone callus, so you should not nail it.
Anything?
You can nail it. It's going to be open nailing, right? So I'm not advocating nailing, but technically, if you're going to nail it, you got to do open reduction and
Even
nailing.
open nailing, you're going to have to ream up and down
Yep.
from the open site, and it's going to be hard to do. You're not going to wrap that nerve. You don't want to wrap the artery. So I think it's open but plating, anterolateral approach.
What kind of plating? Are we using a proximal humerus long plate or just diaphyseal LCDC plate?
Large frag compression plate, 4 or 5 millimeter screws, every time.
I would use in this one probably a proximal humerus plate because it looks a little more proximal. I'm not sure if I need to see how many screws I can get in this non-union scenario. I want to have at least 4 8 cortices. If I don't, I'm going to go probably proximal humerus. You can argue that the proximal humerus screws are not bicortical, but
Yeah.
I feel better.
No, that's a great point. I mean, if it's more proximal and you can't get good enough fixation, but if I'm going to use a proximal plate, then I would add a second plate because the proximal plate is 3-5 millimeter screws. It's not strong enough if you're bridging this long segment.
Excellent. This is fantastic. This is so much fun. Okay, so just as expected, and I have to say thank you, Ed, because this is not, to get to this x-ray in the
Took a
middle
long
took
time.
a long time, and anyway, a long time. And everything, well, like an hour long, but yes, it really did take some time and care. And the one thing you can absolutely do to make this worse is rush and get into trouble. And so everything looks like a nerve, and it was so hyperemic. So she was bleeding quite a bit she had abundant callus. This was trying to heal. You can see that proximal spike, to your point, Mike, was healed for sure.
Right.
It's not perfect, but it's reasonable. And so this was sort of the provisional reduction that I was able to achieve by mobilizing mostly distally. The nasty spike at the distal end, I actually just rongered that off. As you can see in the middle bit there, just to even get it to actually kind of reduce, we'll call it, or be more aligned. And then dual plating with proximal fixation. I'm with you, Uku. There just wasn't enough proximal fixation, and though they're unicortical, there's lots of them. So
That's one thing we didn't talk about in the previous cases was using a small plate initially just to get a reduction, and then I think that's a perfectly valid technique if you want to use a small plate to, maintain a reduction, then span it with a bigger plate. That seems quite reasonable to me.
because you can imagine these are all rounded off edges, so actually to even get rotational alignment is challenging with these cases, so that helped with some provisional fixation. Now here I want to make a really important point. So you finish this, everything looks great, no misadventures, and you go to move her shoulder, of course, and it's very stiff. And so again, just to point out, if these are mobile and a patient is symptomatic, this is going down the non-union road. So earlier intervention can also help with sequelae like a stiff shoulder.
Well, that's a good point. I mean, interop, you could do a release, right? So if she hasn't moved her shoulder in 3 months, you could do a release of all the adhesions, make sure her shoulder's mobile.
What'd you do with her shoulder?
Yeah, so because we had the proximal humerus, just a capsular kind of, and it was just very adherent, and then an MUA once it was fixed, so just a really nice slow stretch. And as you can see, this is a nice fresh one from a couple weeks ago, so I'll report back next year on how she's doing. Great. Good. How are
Great
you?
cases.
Good. Excellent. Any questions? Oh, golly, I don't know if I can remember that off the top of my head. I do apologize.
Why
Can I
you're
ask-
asking this?
Yeah.
Doctor?
Diuretics, both clothalidone and HCTZ, are associated with osteomalacia. They may impair fracture. So I let her internist know she needs to be on another drug, preferably an ARB, because that would increase the blood flow there.
That is, yeah, thank you for that point. So yeah, it also just kind of raises a side point. So when I first sort of met her, she gets the full osteoporosis workup as well. This was a ground level fall. And so we're just optimizing her vitamin D and making sure that we're doing everything possible to optimize her healing potential as well. I did bone graft this because she is 79 and
Where did you get the bone graft from?
I used a synthetic bone graft.
Okay.
I used Infuse on this. She is 79 and I do not want to run into troubles. Yeah.
I mean, I would not use iliac crest of a geriatric patient. That's just.
Yeah, that's just mean. She's been through enough. Any other questions from the audience, maybe for any of the panelists? Yeah, fair enough.
Great. Thank you. Thank you
Thank
for
you,
the great
guys.
panel.